think with COVID, we had a lot of uncertainties about numbers. So she's going to talk to us about, each of them is going to talk to us for about 5 to 7 minutes, and then we're going to open it up for questions from the audience, from whoever, or I can ask them some questions. Paul Orwater is the clinical director for the Division of Infectious Diseases at Johns Hopkins. He was also the past president of the Infectious Disease Society of America. When we had COVID, he ran the guidelines for Hopkins. He was the person sorting through the press releases and deciding hydroxychloroquine, yes or no. And Mark Salkowski is our Senior Associate Dean for Research. He's also a professor of medicine. So he is known for hepatitis C globally. So every drug that we currently use to cure hepatitis C, he was in all the registrational trials. We won't have a cure for hepatitis C if not for the trials that he led. And during COVID, he was tasked with setting up research in a setting where you couldn't see people face to face. And last but not the least, we have Gavin Clarty, who is the head of infectious diseases at Abbott. And his team during the COVID pandemic were the first to identify the COVID antigen test. So I think all of you know the COVID antigen test, you put a test, his team built that test. But when I asked him what was the most, like earlier yesterday or maybe last week, what was the most you've accomplished, and he said getting an e-visa for India. That probably was like one of the biggest challenges in life. So I'll go ahead and turn it over to Shruti, and if she wants to say a few words.
Thank you, Sunil. And I just want to, again, say how wonderful it is to have been a part of today. And just to say, that thinking about all that we've heard today about Suniti Solomon and her legacy, I think relating to that, to some of the things that we're going to speak about today, one of the things that Auntie always implored us to do was to do better, just to do everything better. And I think with COVID, I think we're going to reflect on some of the things that we did well and some of the things that we could do better and learn for the next pandemic. So I'm going to talk about data and surveillance. And when we talk about data and surveillance, I think it's important to think about it in a couple of different contexts. First, there's data and surveillance for pathogens that haven't yet emerged, but might, right? How do you identify those bugs that are going to cause a pandemic? And then there's surveillance once a pandemic has emerged and what you do at that time to inform public health response. I'm going to focus more on the latter because that's sort of the space that I live in, but happy to talk about the first one if people have questions. The other thing, as an epidemiologist, when we think about what data we need, I always say, what's the question, right? So I think it's important to think about what the questions we were trying to answer at the time and what questions we would need to answer in a new pandemic. And I will say for those of us who were working through this pandemic, trying to answer questions, I think one of the challenges was the question changed every day. And by the time we got the data we needed or set up the study we needed to answer the question we were trying to answer, the question changed. And so I think we lived in that insane space. But there are some kind of inherent core questions to any pandemic. First are characteristics of the pathogen itself, right? How does it evolve over time? With COVID-19, I think this came to variants, right? How the different variants caused, how infectious they were, and the severity of disease that they caused. Then basic epidemiologic questions, incidence and prevalence. Seem like simple questions, but with COVID-19, we had, particularly with prevalence at the beginning, wildly varied estimates of the prevalence in a population at any given point in time. And some of this was related to assays, and Gavin will talk some about that, but a lot of it was related to how we were sampling those populations and where the data was coming from. Then it's about who's at risk. Who were the populations that were the most vulnerable to infection? Who were facing the most severe complications? What were the appropriate mitigation strategies, and what was the impact of those mitigation strategies? And again, that comes back to data. How do we know? We need to have a good baseline if we want to know what we're doing is working. And then there's the long game, right? So I think a lot of times we focus, and rightfully so, we focus on the acute phase. I mean, people were sick and people were dying. So we were focused on the immediate questions, but I think many of us know, we've studied a number of viral infections, that it's not just about those acute symptoms. Often there are long chronic complications that may occur in a subset. And we're seeing that with long COVID. And the questions and the data systems that you set up at the beginning are critical, not only for answering those early questions, but those longer ones. And then the other piece to keep in mind is, you all saw a lot of models during COVID. I think everyone became a modeler. Whether or not you had a degree in modeling, you became a modeler and you became an interpreter of those models. But the models are only as good as the data that goes into them, right? So all this that we're talking about, because the model can say, in some ways, whatever you want it to say. But I think when we're trying to forecast what's going to happen, should we close schools, should we keep schools open, that's all based on data systems. So because of, the speed with which we needed to answer questions, I think the first thing that you always do in these circumstances is you take the data that's readily available to you, right? What are the systems that are available? And that's the way you get your quickest answer, but oftentimes those data have the most biases, right? So it's thinking about those biases. And then on the flip side of that, there's the more robust, systematically collected data that don't have those same biases, but take sometimes years to collect. So how do you strike that balance? And a lot of what we did was trying to find the balance between those two.
Sunil asked me to speak about clinical protocols, and I thought I'd first start off with the concept of roving leadership. Just a brief story. I was an altar boy one Sunday at a very crowded church, and suddenly our pastor who was giving a sermon collapsed. And even in a crowded church, only 2 people rushed forward to help, to try to figure out what to do and take next steps. And I was just struck in my few days here in India learning about YRG that Dr. Sunuthi Solomon, yourself, the YRG team also exhibited this concept of roving leadership. You identified a problem, you didn't wait to have someone tell you what to do, you decided to take action, and you certainly have done that in spades. And I think as I reflect to March of 2020, when on March 13th, a national emergency was declared in the United States, within a day, 5 of us decided to meet in a conference room in the afternoon to try to determine what we should do in our hospital system. At that time, I think a lot of people were struggling, would this be a big thing or not? And we decided not to wait. At the time, what did we do? There were 5 of us, and we looked, and there were 6 or 7 guidelines from China that had a whole range of interventions, from herbal remedies, lopinavir, ritonavir, as you know, in HIV medicine, oseltamivir for influenza. Others were advocating hydroxychloroquine or chloroquine in anti-malarial, for example. Others were advocating an antiparasitic, nitazoxanide. How do you choose when there is actually precious little evidence except some, what I might say, almost hearsay evidence from China on what's effective or not, and a lot of conflicting information? And I think as we sort of decide what do we have off the shelf to help our patients, I think some of the things we learned was we not only had those 5 people, but we decided to outreach quickly and got advice from virologists who are certainly in our Division of Infectious Diseases, anesthesiologists, pulmonologists, people that had experience in ARDS, adult respiratory distress syndrome, and emergency medicine. So we were able to solicit a lot of advice and have an engagement, and I think Shruti mentioned many of the facets that are also important in developing a clinical trial when there's lack of evidence. But I think what we learned early on was that we would get some things wrong. I think the early embracement of hydroxychloroquine proved not to be the case, and I think there were some who had pretty good instincts that probably wasn't going to be biologically plausible. But for those of us that trained to follow the evidence in evidence-based medicine, we really didn't have that opportunity here. And I think one of the things that I took to heart is that as we developed guidance over time, we were reading preprints and trying to decide how to move this rapidly. We were making changes rapidly. Luckily, we were in an academic medical center where I think people weren't that upset about rapid change and recognized the rationale for it. But what also became very important is as we crafted advice and revised guidelines, we also had advice from the New York State AIDS guideline team based at Hopkins with Chris Hoffman, since they had rolled out guidelines on how to try to help do something rapidly and effectively communicate. And in the communication, the transparency is very important for engagement and trying to get effective treatments to patients, even when you have some uncertainty, but also the need to acknowledge then when things aren't right, what you might need to change as you move ahead. And I think we are still offering guidance 4 years later to the institution. It's not always followed, and I think some of the challenges are as something becomes more established, and there is an evidence basis, but there's still always nuances that require interpretation and guidance. And as the pandemic went on, even though we had this protocol, what was very important is that we had a weekly meeting to discuss latest science and the current guideline, but also we had daily calls at 7 in the morning with our clinicians who are working in the hospital, and we would try to use some of their experiences to gather information and try to decide what might be working and what wasn't. So in the end, I think when you have a protocol or you wish something to improve, quality improvement or a clinical trial, that's sort of straightforward in the sense you've identified a problem, there's an evidence basis. Here we had no evidence basis, and I think it was so
evening to honor Smriti Solomon and YRGCARE and all the great work that you all do. And I think, as some have suggested, there are many lessons of what has happened in India and through YRGCARE that can be applied to COVID and how we respond to that. Like Paul, I think back to March of 2020, and we did in fact move rapidly, but we did not move very efficiently in the US. People were running around, spending a lot of energy trying to test many different things. And for a brief period of time, we forgot the basics of how we generate knowledge and evidence, how we learn something works. We do that through clinical research. And part of what we had to do in a time where people were driven by fear, anxiety, and concern about this rapidly emerging pandemic, where we didn't know where it was going to go, we didn't know if we would get sick caring for patients, we really had to take a step back and start to instill some of the principles of well-designed clinical trials. Part of what Paul was dealing with was a case report that was published of 10 patients who received a certain regimen, and pretty soon that was being used. We later learned that those were not great ways to treat patients, and when we did better trials with a sufficient number of people, we got the answers we needed about what worked and what didn't work. So the United States, where we like to do things a very slow and rigorous fashion, those of you who worked with the ACTG are familiar with the well-conducted clinical trials. We took time to apply those principles, and what we learned is we need to do that more quickly. We need to have a manner in which we can rapidly adopt a clinical trials framework and do it in a way that is funded with the right people and the right clinical trial sites very rapidly. And unfortunately, that was something that we did not have in place in 2020. I'd like to think we're better positioned today, if that were to happen again, to do appropriate clinical trials. I think the second comment that I'll make, and it's something that we see here and how YRGCARE is set up, we need to marry clinical care with clinical research. The clinical care of patients is how we learn what questions to ask. In the intensive care unit, did patients do better when they were on their stomachs or on their backs? And how do we test that? And how do we design a trial to prove that we could potentially get more oxygen in the lungs of people if they were on their stomachs? Observations that perhaps corticosteroids worked better led to clinical trials that eventually answered those questions. And then the clinical trials going back to inform clinical care and back again. That intersection, linking clinical care to clinical research, is really essential. Shruti talked about collecting data and doing that in a way we're delivering clinical care, but also obtaining blood specimens, respiratory specimens that we can then save and learn more. Many of our discoveries came because we linked our clinical care to our clinical research machinery. I think another lesson to learn, and perhaps a third lesson, is to keep it simple. I talked a bit earlier about how we like to design very complex and scientifically rigorous trials, and there's absolutely a place for that. What we also saw was that situations, and the UK did this with their large studies, where they decided that perfection was perhaps not the goal and speed was more important. They designed large, pragmatic trials. They took their health system and they decided how that they would test certain interventions. So rather than jumping on a 10-person experience with hydroxychloroquine or azithromycin, I can think back to some of the other things that people had tried, like ivermectin, they decided to test those in a rigorous way. They sacrificed some of the biospecimen collection. They sacrificed some of the rigor at which we'd like to collect clinical outcomes. They relied on what happened in the electronic medical record.
So I think I'm the last speaker, so I'll try and be as brief as I can. But it is a pleasure and an honor to be here, to honor Suniti Solomon of the Suniti Solomon Foundation and the opening of YRGCARE, I guess 2.0. But I think the excellent work that's been going on at YRGCARE for the decades, I think this building just really reflects that world-class science and care that's been given for all this time. Well, getting to what I'm supposed to talk about today, the task, I kind of interpreted it as telling the story, if you like, about COVID-19 as it relates to our work in the diagnostics that we built and how we responded, trying not to get a PTSD flashback while I'm doing it. But I hope I can express one thing, is the intensity of the situation, because it was incredibly intense. It was an honor and a privilege to be able to work on a project that impacted the lives of hundreds of millions of people and to really be at the forefront of responding to the pandemic, because I think, as you are aware, before there's vaccines, before there's therapeutics, the only thing that you can put in a doctor's hands or in the public health community's hands is a diagnostic test, and it is the first line of defense. But again, this is not Abbott's first pandemic, so that's kind of something that we could rely on. And I don't know if you're aware that Abbott built the first HIV test to protect the world's blood supply back in the day, kind of linking it back to HIV, and also hepatitis B surface antigen, et cetera. So we have a history of responding to pandemics in this way. But this one was a little bit different. I think we started looking at the situation in December of 2019, and it was kind of like the storm clouds were gathering, and we were waiting, but not really able to respond until the first sequence dropped. And when we got that first sequence, we were able to kind of spring into action. But in the interim, we were debating. Actually, there was a lot of debate at the senior level about, is this going to be another SARS? Is this going to be MERS? Is this going to pitter away? So we were watching what was going on, and it was very clear, at least to our group, that this was not going to be another SARS, and this was going to be the real deal. But that was very ominous to see that coming while you're waiting for the ability to start responding and knowing the kind of pressure that would be on. But we were learning all the while and reading up on SARS, on MERS, and what we could learn about other coronaviruses to try and make the right decisions early, and that proved very useful. We weren't sure exactly what tests we were going to need. So it was kind of like, we're going to need a toolbox. Which ones do we prioritize? We're going to try and prioritize building all of them. But it really was clear that we would need to be able to identify people who are actually infected. That was going to be the critical part. Differential diagnosis, so PCR tests, antigen tests, all of these things would be important. But we also knew that serology tests would be important to understand immunity, to see whether somebody was protected, how long this lasted, contact tracing from a public health perspective. So we actually started multiple teams, and we were fortunate in that we had alignment and support from the very top level at Abbott, and who basically gave us the all hands on deck. This is the most important thing for the corporations. Drop everything, and that aligned the whole corporation.
People are generally very wary of vaccines nowadays, at least in the United States. But what I found most important is that we would have education sessions for the staff, because what we found was if a patient comes in and asks our advice, they may or may not take that to heart, but then they would go and ask the person at the front desk who's checking them in, what do you think about this vaccine? And if you don't have everyone in your organization on board, or at least conversant with it, they don't maybe have to agree with you, but at least make sure they have the information about something that's new, something that's different. I think that's very important. And I think people are desperate. I mean, they're really looking to do something. I mean, and there's potential harm, as we learned with hydroxychloroquine and chloroquine. So, you know, I think when people want to do something, maybe, you know, it's very hard to get them to do something else, but people like to feel like they're in control in these situations. And that's why sometimes, you know, we argue and say, well, let's at least have some supportive care. Most of the things that we have, there's no evidence that taking guaifenesin for your cough or cold works really, or dextromethorphan or so on. But at least we don't think they do harm. And I think when you have pharmacists, my hopes are that I think that's such an important piece of this nowadays, certainly in the US and certainly in many countries of the world, that I think pharmacists have to be as engaged and stakeholders in trying to help solve and provide something that's credible without doing harm to people.
Thanks, Bob. Are there any questions from the audience?
Us in India for the next pandemic?
I mean, I think a lot of the things that we've been talking about, and I think what we have to do in India is what we have to do everywhere, right? I think first is that I think it's tempting right now to forget what's happened. I think everything to break down, I think Mark mentioned the situation with SARS-1, you know, versus SARS-2, the fact that the hospital was closed down. I think, you know, shutting down systems that were set up for COVID, you know, is a mistake, and thinking about how we can learn from those things and set up surveillance systems and early identification. So that's the first thing, is to just not forget. I think it's tempting to want to put that behind us, and we shouldn't do that. I think I talked about, I think how, you know, some of the things that we're doing in the U.S. and that's happening is trying to have routine surveillance for symptoms and things like that that are unusual. I think that there's, you know, the early identification is critical, I think, with COVID, and oftentimes we feel like we're chasing, you know, we're behind. Things have already emerged, things have already spread. So I think implementing methods to be following, to be surveilling for symptoms and changes in symptomatology, even for respiratory infections, right? Just kind of looking at whether there are changes in those year to year. It's a complicated question because I think it's multiple facets. I think we talked about a lot of different things here, but that's just an additional thing that I would add. I don't know, I'll leave it to Gavin.
You know, it is a complicated question, but I think the first thing, to echo everything Shruti said, but it's to be looking, to be vigilant, not to go to sleep. And that's what we're trying to do with YRGCARE. I think there are many different ways that you can go about it, and we're trying to experiment with some of those, whether it's working with physicians because they're the first people who are going to be seeing patients with illnesses that they can't explain. Don't ignore that. Also, networks that are looking for one specific thing, like influenza, and you've got somebody who's severely ill, but it's not influenza, and then they throw the samples away. That's crazy. You know, the negative samples in these types of scenarios are golden. That's what you should be looking for. Or innovating around electronic medical records that we've been trying to. It's more challenging than you would think, but there's a lot of data that's being captured on a routine basis with this new era of AI and data analytics. How do we screen the data that's already there to find the cases that might be worth a closer look? And one of the things that we found in our study doing this at Rush is having the staff who are trained to engage with the patients and enroll them such that they're willing to participate and remove the barriers to that part.
That were conducted at JHU and did impact our clinical practice quite a bit. To give an example, hospitals in India wouldn't see patients without having a CT done. Okay, so if they were to be seen by any doctor going in for COVID, they have to get a CT done. So I had a tough time convincing my patients, you don't need a CT, don't worry about it, we can manage it. And it's not routinely recommended. So the biggest challenges was, where do you get these information during such times, you know, because there's so much information floating out there, and what is your advice?
I'll let others speak to the clinical information, but I do think that one of the things that I mentioned is just sharing and collaboration. You know, one of the things that happened at Hopkins that I thought was really fantastic was there was this group of faculty, postdocs, and students that would put together these research compendiums. You know, their literal job was to scan the literature and summarize. Because I think, as Gavin mentioned, I think for all of us, it was so challenging to keep up with the literature. And the literature was not just peer-reviewed papers, but it was coming out in case reports, it was coming out in media. And so I think having those places where there is expertise to pull that information together, so I think that was happening in some places, but I think we can probably do a better job of disseminating that information broadly. I don't know if others want to speak to the clinical.
Well, I think it's actually a challenging point you raised, and I'm not sure we have the answer to it because there are so many ways to disseminate information. So right now, it's very routine for scientific papers to be in pre-peer review format, and in general, that's good. And during COVID, during this early time where we were searching for anything we could do, people were sharing through Twitter, now I suppose X, and other formats. Some of that was great. Some of that brought information people needed, but many of those messages were actually negative messages, sending the wrong message, or disseminating things that actually increased distrust of medicine across the system. So the confusion is really hard to control. I think what you saw emerge, we were fortunate at Johns Hopkins, where that information from clinical trials and clinical papers got funneled through a group of experts, and what came out was a consensus of trust this, don't trust that. That slowly came, at least from other bodies, where they helped us sort through that data. But it